The next speaker is Matt Mauck. It's been really fun getting to know Matt well in the context of the backpack study. It's one of the big studies in the HEAL initiative. It's a precision medicine study in low back pain. Matt is at UNC. He's an associate professor in the Department of Anesthesiology and the vice chair for research. Matt is a MD PhD. He's going to be talking about today about low back pain, but if you really want to see Matt geek out, ask him about green light and about shining green light in people's eyes, because he also has a PhD, and he has some really cool science that he's doing now, looking at different types of light therapy. But I think that's the other side of Matt that he's probably not going to be talking about today. So.
Thanks, Dan, for that great introduction, and thank you for the organizing committee, Afton and Dan, and thanks Sarah and Jess for the wonderful support in coming here. It's a real pleasure. Before I get started, I want to just highlight on the bottom of my slides, there's some white text that is there to thank all the collaborators that have helped us conduct the study that I'm going to talk about today. BACPAC is, as Dan said, the Back Pain Consortium, which is a team science initiative that NIH funded through the HEAL initiative. And this work could not be completed without a large number of individuals. And I think most pain researchers have been involved in this project, which has been a lot of fun. And so today I'm going to talk about working towards a precision medicine solution for chronic low back pain. I wanted to start out, and I just want to thank Dan, Bridget, and Jeff for setting us up so nicely, and that chronic low back pain is a chronic overlapping pain condition. And a recent study from the University of Pittsburgh where they looked at chronic overlapping pain conditions shows the distribution of conditions that are associated with chronic low back pain. And in this cohort, 32% experienced migraine headache, and the second most common chronic overlapping pain conditions that's seen in chronic low back pain is irritable bowel syndrome. And so these are overlapping pain conditions that likely have similar mechanisms, and we'll talk about that as we go through the talk. Chronic low back pain is the fourth most common reason that individuals come seeking health care. It's a major problem that we face, and it's complicated because it's a complex condition that's not easily explained by imaging or any other diagnostic test. And it's a leading cause of disability, so it causes a lot of problems in our world, and so it's a really important problem to work together to try to fix. And some of these problems and complexities come from the fact that we have a lot of different treatments that we can use to treat chronic low back pain. I've listed several here. This is not an exhaustive list, but a fairly comprehensive list of the treatments that we use to treat patients that have chronic low back pain. The problem is these treatments don't work all that well. Most of them have a modest effect size at best, and many of the treatments do not work, as is illustrated in this recent systematic review. And that's possibly because only a subset of individuals respond to a given treatment. And we really need to work to try to understand what makes that piece of the pie who respond to treatment unique, and what makes them respond to one treatment but maybe not another. The biological mechanism of chronic low back pain is complex and not fully understood. I think one of the best examples I can give of this is imaging. We do a lot of imaging in this country to try to explore individual symptoms. And this is from a famous New England Journal of Medicine article in the 1990s showing that this L5-S1 disc bulge is from someone who does not have any pain. So just like Dan showed with the knee x-rays, you can have a completely normal x-ray and have pain, and you can also have a completely abnormal x-ray and not have pain. Same thing with lumbar MRIs, is that we often find findings on these MRIs that we think explain an individual's pain, only to find out that it's more complicated than that. So we just really need to focus on treating the patient and not the imaging. Further complicated in managing patients with chronic low back pain is the fact that there's really limited guidance for clinicians at the bedside to make clinical decision making. So our solution that the Back Pain Consortium came up with is to really focus on precision medicine and take a more precision medicine approach to try to understand what makes individuals unique and how do we better target therapies to those individuals. There's two companion studies that were performed to try to get at this problem in chronic low back pain. There's a sequential multiple assignment randomized trial that was performed here at the University of Michigan. And then the Back Pain Consortium, together as a team science initiative, had a collaborative clinical study that's now known as the BEST study, which stands for Biomarkers for Evaluating Spine Treatments. And we're going to spend the most of the talk talking about that particular study. And the objective of our study was to conduct a collaborative adaptive trial, which is known as a sequential multiple assignment randomized trial in chronic low back pain, so that we could estimate an algorithm to assign the optimal treatment to individuals based on their phenotype, and also to explore biological mechanisms of chronic low back pain so we can learn more about why individuals experience chronic low back pain. This is the study schema. And I want to start out by just saying that we designed this trial to be pragmatic and treat patients just as we would treat them in a clinical setting. So there's 2 treatment periods, which is how it gets the name sequential in sequential multiple assignment randomized trial. And so patients are enrolled in the study, undergo a run-in period, and then come for their first visit, where they're randomized to one of 4 treatments. The 4 treatments we selected were highly evidence-based treatments for chronic low back pain. The first is enhanced self-care, which is a self-management program that heavily utilized the University of Michigan Pain Guide, developed right here at the University of Michigan. Acceptance commitment therapy, which is a pain psychologist-delivered intervention, as well as evidence-based exercise and manual therapy, which is a physical therapy intervention. And the last therapy that we assigned individuals to was duloxetine, which has a high evidence base for treatment of chronic low back pain. Then individuals went on for 12 weeks on that treatment and came back to see us after the 12-week period. At that point, based on the response to the first treatment, if they responded very well, they were continued on the first treatment in the second phase of the study. If they had a mediocre response, they were augmented. They continued the first intervention, but then were augmented with an additional intervention that we layered on top of that first intervention. Finally, if individuals didn't respond well, they were re-randomized to a completely new therapy for the second 12-week treatment period. And then individuals came back for follow-up with us, and we followed their symptoms throughout 36 weeks, but there was 2 12-week intervention periods in this study. And these are the interventions, and I just wanted to list this here to thank everyone that was involved in developing these interventions. This took a team to develop each one of these interventions and deliver it with high fidelity across 12 sites throughout the United States, which are all listed here. I hope you're beginning to see the amount of team science that happened in this project, which I think is really an exciting aspect of this project. And so thank you to all the site PIs that were involved in enrolling these participants, as well as the team at UNC who helped coordinate this effort. Successfully, we were able to enroll over 1,000 patients in this trial across these 12 sites. So just special thanks to all the site PIs for doing that. And then once we enrolled 1,000 patients, or just over 1,000 patients in the study, and after the run-in period and based on an eligibility recheck, we randomized 800 participants to one of the 4 treatments. And each treatment, I've listed the number of participants that were assigned to each treatment. So it's a pretty balanced across the 4 treatments, with about 200 participants in each treatment arm. The primary outcome of this study was the Pain Enjoyment of Life and General Activity Scale. And I'm going to show you the primary results of these groups based on their 12-week assignment. So the first period, they were assigned to one of these 4 treatments, and you can see the outcomes in terms of the Pain Enjoyment of Life and General Activity Scale, which is plotted on the y-axis. The x-axis is the 3 visits that the participants in the study underwent. So you can see that all of the treatments provided benefit on a population level to the participants that we enrolled in the study. If we were comparing, which we are not, you might say that the physical therapy arm did the best, duloxetine second best, acceptance commitment therapy third best, and enhanced self-care fourth best. But that's not really what we did. We did not do a comparative effectiveness trial. Has anyone been to a Milwaukee Brewers game? I spend a lot of time. It's summertime, and I want to make a baseball analogy. Well, in the sixth inning, if you go to a Milwaukee Brewer games, there's a sausage race. So there's 5 sausages that race around the baseball field. And the goal is for the fans to choose one and cheer them on and see who wins the race. So we weren't cheering on a particular intervention in this study. What we were trying to understand is how the sausage is made. What makes the chorizo sausage, who's winning the sausage race, different than the American sausage who didn't win the race? And how can we better treat the chorizo sausage? I'll stop with the sausage analogies, I promise. And so the secret sauce of the BEST trial was to really understand phenotypes. What makes individuals unique and what makes them therefore respond differently to treatments? So understanding what phenotypes drive differential treatment responses was a critical goal of BEST. And we collected a lot of phenotyping on individuals. I've listed it in a table here and listed the individuals that helped us decide how to phenotype individuals in this trial. So thanks to everyone that was involved in that endeavor. So this is complicated, and I want to break this down a little more simply for us to understand. And I chose 2 areas to focus on in the 12-week outcomes. So we're just going to focus for the rest of the talk on the 12-week outcomes of the BEST trial. And we're going to explore 2 candidate biomarkers to predict treatment response or differential treatment response in individuals that were enrolled in the trial. The first we'll talk about is nociplastic pain. And because we've had a lot of talk already about cytokines and inflammation and the role in nociplastic pain and chronic overlapping pain conditions, I'll show you some data on our cytokines that we collected in predicting differential treatment response. So I think most pain practitioners and individuals that see patients in pain would argue that the pain diagram is the most important piece of data that we get to manage patients. This is a patient I saw last Monday, and they circled the entire body. So I think this is a surrogate marker for nociplastic pain. The number of body regions that individuals experience can be a marker for how that individual experiences pain. And this was definitely a main topic of the visit. And we've really, I think, the previous talks have done a great job defining nociplastic pain, so I won't go in more detail, but just to know that we can use the widespreadedness of pain, the number of body regions that are painful, as a surrogate marker for nociplastic pain. And this is the distribution of pain areas in our cohort. So we were pleased to see that we enrolled, indeed, a cohort that had low back pain. So that was the most common complaint or region of the body that was painful. But what to notice is the panel on the right, where 22% of our cohort had pain in more than 4 body regions. And it's fairly common for individuals with chronic low back pain to have pain in more than 1 body region. So we asked the hypothesis that with individuals with nociplastic pain, or individuals with high widespreadedness of pain, we predicted that they would respond better to central acting treatments like duloxetine and acceptance commitment therapy. So we fit a model to explore this using the 12-week PEG as the outcome and adjusted for baseline PEG, age, sex, and the number of treatments that someone was eligible for at baseline, which turns out to be a really important factor because some individuals weren't eligible for treatments like duloxetine. Then we tested the interaction between the treatment effect on PEG and the number of body regions that were affected, and plotted those estimated means across all of the other model values. So when you look at this data, imagine that this is the average BEST participant and their response based on how they would respond if you isolated the variable of widespreadedness of pain. And these are our results. So just as we predicted, we found that individuals with low widespreadedness of pain responded the best to the physical therapy intervention, whereas individuals with high widespreadedness of pain responded best to acceptance commitment therapy. That's in line with what we expected. What was surprising is if you look at the slope for duloxetine, you see that as widespreadedness increases, the response to duloxetine decreases. And this was puzzling to us. So we dug in and tried to figure out what was going on here. And the first thing I wanted to show is the distribution of participants in each treatment arm by their widespreadness of pain. So we just did a count, a simple histogram of participants in each treatment arm based on their widespread pain variable. You can see that if you look at the duloxetine intervention, we're missing a lot of people with widespread pain. The other interventions had sort of a nice distribution, whereas duloxetine sort of enrolled a lot of individuals with low widespreadness of pain. So we think this might be a factor in why we saw what we saw. And to complicate things further, we found a three-way interaction. So these are really hard to explain, so let me try my best to do it and illustrate it to you. So we find that if we take that same plot that I showed you before, where we have the widespreadness of pain on the x-axis and the pain severity score on the y-axis, we've plotted the response to treatment in that same plot I showed you before. But we've plotted this with 6 different plots based on the baseline pain severity. So it turns out that the interaction changes as we move from low baseline pain to high baseline pain. So if we plot the response to duloxetine, we see that if you have if an individual has low widespread pain and low baseline PEG, they have this characteristic response to duloxetine. As we move to higher widespreadness of pain, there's a worse response to 12-week PEG. However, as you go to higher levels of baseline PEG, we see this invert. And based on having a high baseline PEG and high widespreadness of pain, duloxetine works, turns out, really well for those individuals. So hopefully I've done a good job of explaining a three-way intervention for three-way interaction for any of the statisticians in our audience. But thanks to this group of individuals who helped us sort of through this. So how could this be useful? This seems really complicated. I think this is extremely exciting because this is what we hope might happen, is if you were taking care of somebody in your clinic and they had high pain severity and had nociplastic pain, you might assign them to duloxetine because that's what this data sort of points to. However, if you had low widespread pain, low nociplastic pain, high widespread pain, you might rather go for acceptance commitment therapy for those individuals. So I think that hopefully what I'm illustrating is this data can be very useful for clinicians in understanding how patients that fall into different categories and different phenotypes might respond better to treatments. This is a preliminary result for just conceptual purposes only. I think we have a lot of work to do to really validate that this is and indeed our finding. But I wanted to share with you at least some promise of this data to help us along with our patients clinically. All right, so hopefully just as an overall conclusion, I've convinced you that it seems that for duloxetine, the differential treatment effect is really dependent on baseline pain. All right, we'll move on to cytokines. We have been following this literature for a long period of time, and we know that chronic pain is related to inflammation. There's been a lot of really groundbreaking work done with microglia and T cells and showing that these cells are really important in maintaining and initiating chronic pain. And further, in chronic low back pain, there was a recent study by Luda Diachenko's group showing that a blunted immune response was important in the chronification of acute low back pain. And so individuals that weren't able to mount a robust immune response in the early phases of acute back pain ended up going on to develop chronic pain. So this was also further shown by Jeff Mogul's group, who gave an anti-inflammatory drug, dexamethasone, in the early aftermath of an injury of a CFA model, and showed the same thing. If you blunt the immune response early after an injury or an insult, pain tends to chronify. So we asked the hypothesis in our cohort is that if individuals are able to mount a robust immune response, will they respond better to treatments that have inflammatory mechanisms like duloxetine and EBM versus an intervention that has a low likelihood of treating an immune response or modifying an immune response. So thanks to a tip from Andrew Schrepp, we collected these true culture tubes, which enabled us to collect blood from individuals in the study, and then stimulate the blood for 24 hours with lipopolysaccharide, which is a toll-like receptor 4 agonist. And then we are able to extract the plasma and assess cytokines. This is the panel of cytokines that we assessed in this cohort. And then we performed a principal component analysis and developed a principal component that captured the overall magnitude of the lipopolysaccharide-induced cytokine response and captured about 68% of the variance. I've plotted that here versus the baseline PEG pain intensity, and you see that a blunted immune response is associated with greater pain intensity at baseline. However, this principal component did not show any differential treatment response in response to the 4 treatments in the BEST trial. We therefore then looked at individual cytokines because since this is a principal component analysis, we might have missed something if we didn't look at every inflammatory cytokine. So we did that and found an encouraging result for MMP9, which is secreted by leukocytes in response to an inflammatory stimuli. And the role of MMP9 is really to promote immune cell migration. And what we found is that high MMP9 levels at baseline predict a better response to duloxetine relative to ACT. Just as we predicted. However, I want to be very clear that this was just, although individually significant, it was nominally significant because it did not survive multiple comparison testing. So I think that, in conclusion, I would say that cytokines alone are going to be very unlikely to help us with treatment planning, but potentially combined with other data points, it could be useful. The next steps with this trial are to collaborate with all of you. And to share this data far and wide so that we can use it to answer mechanistic hypotheses about chronic pain. We have a precision medicine analysis that's underway, which is the primary analysis of the trial, and I'm not prepared to share that data with you yet. But hopefully soon, we'll get that out to everyone so that you can start to think through this alongside us. And then we'd hope that the scientific community can make really high use of this data set. And it is available to the community through a data access and publications committee request. If there's any need for help, just don't hesitate to reach out to me. I'm glad to connect you. And just wanted to thank everyone that was part of this Team Science initiative. In summary, mostly our study participants who gave a lot of effort to participate in this study, which was very involved. And thanks to our funders and the team that helped put this science together. I'll be glad to take any questions if we have time for them.
We have time for a question. Anyone? Paul.
Matt, it is beautiful data, and it's going to be unbelievably rich in helping us answer some questions. And you hit something at the end that I think is really important, and that is that whenever we've looked at cytokines, we only see they're relevant if they're combined with other features. And for example, when we looked at prediction of chronification of people with back pain after an acute episode, again, we saw the blunt response being related, but only if it was associated with poor sleep and depression. So do you have sufficient numbers of participants to be able to probe the associations with other psychosocial features and lifestyle factors?
Definitely. I think we have sufficient, we have all of those data ready to analyze it. I did not incorporate that into the analysis at this phase, but you're right, we do have that data, and that's going to be really interesting to explore as we move forward and to validate some of these hypotheses that we've seen turn out to be the case in other scientific work, such as yourselves.
And one of the things that you kind of converged widespreadness with being nociplastic pain, and
yes.
And maybe your data actually has some better opportunity to identify who the people are who have nociplastic pain by combining some of the other measures that you have. So it'd be really nice to see whether those things actually fine-tune the outcome prediction.
I think you're right on, and we hope to also combine to increase our power with other data sets that have been collected as part of the consortium, like the University of Michigan SMART. There's some of the interventions that were the same we used across trials. So I think it provides us a really good opportunity to explore this further, and we do have rich data on phenotyping and can do a better job, I think, than what I did here. In characterizing nociplastic pain features in these participants. We've looked briefly at some of the somatic symptom scores and severity scores, and we're seeing very similar trends if we incorporate those into the model. But for simplicity, I thought I would just show this for today. Thanks, Paul.
Great, and thanks, Matt.